Good morning, everybody. I'm Dr. S. Ramakrishnan. I'm a senior consultant rheumatologist attached to Apollo Main Hospital. Now I'm practicing in Apollo Clinic, Apollo Medical Center, Anna Nagar. My experience in rheumatology has been for about 40 years. And all these years, I've been given the opportunity by the Creator to teach the medical students. I thought that I should share my knowledge and experience with the medical fraternity. So I am decided to do a CME on rheumatology. The first topic will be approach to a patient with joint pain, which will be a pictorial presentation. I'll walk you through the corridors of clinical rheumatology. The second topic will be on laboratory investigations in rheumatology. Then after that, I may have 4 to 5 lectures on drug treatment in rheumatology. This will enable you to identify rheumatological disorders in your medical education. Now, rheumatology is a very interesting specialty, and one should have a very strong foundation in internal medicine also. Now, one important point with respect to any medicine, any branch of medicine is we should not forget Hutchinson's principle. All of us would have read that's a Bible in medicine, starting from the third year of medicine. Taking history has become history. Why no clinical examination is a mystery. Doing lab tests is a rule. Is it to make a purse full? The point is, any specialty, you have to follow the routine of taking a history exam. With the history, you should come to some provisional diagnosis as to which system is involved. Subsequently, you do a clinical examination to confirm the clinical diagnosis. And last but not the least, you do laboratory investigations to clinch the diagnosis. If in the history and clinical examination you do not come to some probable conclusion, you will never come to a conclusion at all. So I feel personally to request to all the medical students that you have to do a proper clinical examination after taking the history. So approach to joint pain. Now why should I speak about joint? Rheumatology is connected with the joint and the surrounding structures. So the clinical manifestation of these patients are invariably with joint pain. So the diagnosis includes a good history, a very relevant clinical examination, and investigation. So let us go into the history with respect to rheumatology. The first problem that people experience is joint pain. So you should ask how long the joint pain has been of duration and has been whether the onset has been acute or gradual and whether there was any swelling in the joint. This swelling in the joint can be persistent or it can be migratory or additive. What do you mean by migratory joint pain? Migratory joint pain is the joint pain splitting from one joint to another. Example, suppose if I have migratory joint pain and arthritis, I'll develop a swelling of the wrist, left wrist, that persists for 2 days, then it may go to the right wrist. But when it goes to the right wrist, the left wrist will become all right without any residual deformities and residual synovitis. So that is called migratory joint swelling, migratory arthritis. The common causes of migratory arthritis are rheumatic fever, number 2, systemic lupus, number 3, sarcoid arthritis, number 4, occasionally Hansen can also cause migratory arthritis. And then we have an entity called palindromic rheumatism. Palindromic means it comes in episodes. Rheumatism is affecting the joints. So these are the 5 important causes of migratory arthritis. You should also know whether it is additive or not. Additive means additional joints are involved during the course of the disease. Example, if my left wrist is involved as presentation, then what will happen is in a few weeks, my right wrist and my right elbow will get involved. but that time my left wrist will still have the residual synovitis. So that is additive. A classical example of additive arthritis is rheumatoid arthritis, which is a classical rheumatological disorder characterized by inflammatory symmetrical polyarthritis affecting the smaller joints of the hands, the fingers, the toes, the knees, associated with early morning joint stiffness lasting for more than 30 minutes. Then, so we finish with respect to joint pain, joint swelling, whether it is migratory or additive, and then the distribution of the joint pain is very important, whether the joint pain is symmetrical or asymmetrical. Symmetrical is the hallmark of the king of rheumatological disorders, rheumatoid arthritis, bilateral symmetrical inflammatory arthritis. Asymmetrical. Asymmetrical arthritis occurs usually in the seronegative spondyloarthritis group, like ankylosing spondylitis, psoriatic arthritis, arthritis associated with inflammatory bowel disease. Yeah. Now I want to give one small explanation here. What is this rheumatoid arthritis and what is the seronegative spondyloarthritis? Initially, every patient with arthritis was diagnosed to have rheumatoid disease. Then they took the group of patients in whom rheumatoid factor was positive, and hence they christened them as rheumatoid arthritis and seropositive rheumatoid arthritis. The other group, in which the rheumatoid factor was negative, they named them as seronegative arthritis. This seronegative arthritis, subsequently they found it involved the sacroiliac joint, and hence they coined the term seronegative spondyloarthritis, which is now termed as spondyloarthritis. So you get symmetrical distribution and rheumatoid arthritis, asymmetrical distribution of the peripheral joints in patients with spondyloarthritis. Early morning joint stiffness is the hallmark of inflammatory joint disease. What will happen is when these patients get up in the morning, the joints will be very stiff. They would not be able to move their joints. If the wife has got rheumatoid arthritis and she got severe early morning stiffness, she won't be able to make a fist and box with the husband in the early morning. This duration of early morning joint stiffness may last for about 30 minutes. Early morning joint stiffness is a characteristic feature of inflammatory joint pain and very characteristic of rheumatoid arthritis. In fact, it is included in the classification criteria of rheumatoid arthritis. Whether the onset of the pain has been acute or gradual. Acute onset, a classical example will be septic arthritis. A gradual insidious onset will be rheumatoid arthritis or psoriatic arthritis. In the history, you should also ask them for joint deformity, because when they have joint deformities, they would not be able to do their activities of daily living. That is very difficult. See, one thing you should not forget with rheumatological problems is it is associated with joint pain and it is associated with deformities and physical disability, and this leads to a lot of psychological and physical dependence on others. So if you have somebody with arthritis at home, you have to be very sympathetic and empathetic to them and very considerate to them, because it is for no rhyme and reason they develop the arthritis. Philosophically looking, one could say it is due to karma, but one thing, when the patient is suffering, you can't keep talking philosophy. Now, that is one with respect to joint pain in the peripheral joints of the appendicular skeleton. But then you have to ask questions about low back pain, because there are certain rheumatological disorders like spondyloarthritis which has an element of peripheral arthritis. So you should ask whether the patient has got low back pain and at what duration it is. If it is an acute onset of low back pain after a strain, you may have to think of a lumbosacral strain or intervertebral disc prolapse. But if it's a chronic long-term duration, you'll have to get into the nature of the back pain. Please concentrate in the next few minutes at least about low back pain, diurnal variation. If the low back pain is worse in the night and early in the morning, becoming better as the day progresses, it is inflammatory low back pain. To repeat again, Inflammatory low back pain is a back pain which is maximum in the night, early in the morning, becoming better with activity, and that's very characteristic of inflammatory low back pain. It's characteristic of spondyloarthritis, characteristic of ankylosing spondylitis. In fact, a diagnosis of ankylosing spondylitis is a telephonic conversational diagnosis. We just ask the pain when the pain was maximum and when how is it relieved. If the back pain becomes better with activity, it is inflammatory low back pain. If the low back pain becomes worse after physical activity and relieved by rest, it is mechanical low back pain, which could be due to spondylosis or intervertebral disc pathology. So this is very, very important. A patient with arthritis who has got low back pain, worse in the night, worse in the morning, becoming better as the day progresses with activity, well, your clinical impression and diagnosis, even in clinical history, will be spondyloarthritis, and you have to examine for the evidence of ankylosing spondylitis. So this is a characteristic patient with ankylosing spondylitis. You find that he's got a kyphosis, and very characteristic of them is that once the disease progresses, they wouldn't be able to flex the lumbar spine or extend the lumbar spine. The neck gets involved, the neck gets totally ankylosed. It's very disabling to have ankylosing spondylitis. Nowadays, what we rheumatologists tell everybody is identify the arthritic disease as early as possible and start the treatment so that the disease does not progress and you can prevent disabilities. We are in the era of preventive health care, so prevention is better than cure even with respect to rheumatological diseases. History personal, family history of similar illness. You can ask me a question. If suppose I have psoriatic arthritis, the first question you will ask me is there a family history of psoriasis? Because psoriasis runs in families. Sometimes people can have, usually in psoriatic arthritis, the skin lesion will precede the arthritis. Occasionally, the arthritis will precede the psoriasis. In such situations, if a patient gives a history, family history of psoriasis, you can take it for granted that this patient will ultimately develop psoriatic arthritis. Exposure to the sexually transmitted diseases is very important because people can have syphilitic arthritis, gonococcal arthritis, and not but not least arthritis associated with retroviral infection. History of blood transfusion again is very important because people can have an arthritis associated with hepatitis B and hepatitis C. Hepatitis C is associated with vasculitis, like manifestations in rheumatological patients. So that's why we do the blood for anti-HCV in patients have arthritis in whom it's not diagnosed as rheumatoid. Preceding upper respiratory infection. Now there are 2 points here. Preceding upper respiratory infections in the children, the pediatric age group, when it's followed by arthritis, all of you know it's taken against rheumatic fever, and you have the modified Jones criteria to make a diagnosis of rheumatic fever. But there is an entity called reactive arthritis. This sort of reactive arthritis, post-streptococcal reactive arthritis, occurs in the adults. They have a respiratory infection, they follow which they have an arthritis, and they do not fulfill the modified Jones criteria for rheumatic fever. So that is called post-streptococcal reactive arthritis. Reactive arthritis, please jot down. Reactive arthritis is an inflammatory arthritis in which occurs secondary to a focus of infection elsewhere, either in the gastrointestinal tract or in the genitourinary tract or the upper respiratory tract. That is called post-streptococcal reactive arthritis. When it's associated with diarrhea, you call it as post-diarrheal reactive arthritis. When it occurs secondary to genitourinary infection, you call it as the post-urethritic reactive arthritis. That is why in all patients with arthritis, you should ask a history of preceding diarrhea the last 2 to 3 weeks. That's very important. Post-diarrheal reactive arthritis is very, very common in India. So any patient who comes to you with an asymmetrical arthritis involving the larger joints of the body, you should please ask the history of diarrhea in the preceding 2 months. And this diarrhea is secondary to salmonella or shigella. Abdominal pain with joint pain. Abdominal pain with joint pain. please think of vasculitis, because systemic vasculitis can present as abdominal pain. The characteristic disease which presents with abdominal pain and joint pain is polyarteritis nodosa. You know that polyarteritis nodosa, where you have multiple aneurysms and stenosis in the abdominal vessels. It's a very bad disease to develop because it is associated with great morbidity and mortality. Similarly, you'll have to ask for passage of blood and mucus in the stools. A patient with joint pain or arthritis who has got a history of a dysentery-like picture, please think of the possibility of inflammatory bowel disease. Recently, I had a patient who had presented to me with joint pain, and then and with blood and mucus, and that she was diagnosed to have Crohn's disease. So please think of gastrointestinal problems when patients present with abdominal pain, blood and mucus in the stools associated with joint pain. History of UTI, I told you, post-urethritic type of reactive arthritis. So if somebody develops a urinary tract infection followed by arthritic problem, you will have to think of post-urethritic reactive arthritis. Now, I'll be going now to the pictorial presentation, history of fever, history of oral ulcers, history of skin rash, cardiac disease, red eye, increased hair fall, disturbance of vision, severe temporal headache, history of swallowing difficulty. Now, each of it, I'll give a pictorial presentation I will present. You can just jot down or take a photograph of the slide and keep it. Other important extra-articular symptoms. Rheumatology is not a disease which is confined only to the joint. Extra-articular involvement is very, very common and very, very important from the point of view of diagnosis. Please mute, please. Yeah. Thank you very much for the silence. Like the Buddha, I like silence. History of extra-articular symptoms. History of nasal stuffiness with epistaxis. You can wonder why. There's a disease called granulomatosis for polyangiitis called as Wegener's disease, which presents as resistant sinusitis with epistaxis. Difficulty in hearing. That is also a characteristic symptom of patients with Wegener's. Photosensitivity is characteristic of systemic lupus. History of Raynaud's phenomenon. Raynaud's phenomenon is a triphasic phenomenon in which the fingers will become blue, then they become white, and then they become erythematous. It is due to vasospasm of the blood vessels. It is seen in patients with scleroderma. So when anybody you see with Raynaud's, then you will have to examine for patient evidence of scleroderma. That's important. Then, so the Raynaud's is characteristic of connective tissue disease. In the management of Raynaud's symptom, the most important point is they should wear, the protection is very important. Wearing of woolen gloves or cotton gloves, not to keep the hands in cold water, to keep away from the freezer and the refrigerator, and not to keep the hands and keep washing for a long period of time in cold water. History of chronic cough with or without hemoptysis. So this is a patient who's got joint pain associated with chronic cough with or without hemoptysis. Here, the respiratory tract will get, means that there's involvement of the respiratory tract. It can be involvement of the pleura. It can be involvement of the parenchyma. It can be involvement of the vasculature like pulmonary artery hypertension. So very important, you'll have to think of diseases which affect the joint as well as the respiratory tract. When it comes to breathlessness, this breathlessness can be of cardiac origin or it can be of respiratory origin, or it can be hematology, even anemia. Please jot down this point about anemia in rheumatological diseases. A patient who has got anemia with a rheumatological problem can present with cough, with breathlessness, and even cardiac failure. Now, what are the causes for anemia in a patient with an inflammatory disease? It could be a part of the inflammatory disease. It could be unrelated to the inflammatory disease. As a part of the rheumatological disease, anemia, you'll have to think of immune hemolytic anemias, which are seen in patients with systemic lupus. So if you suspect immune hemolytic anemia, you have to do the reticulocyte count you have to do the Coombs test, both the direct and the indirect, and then you have the LDH, which will be elevated. And these patients, if the anemia is very severe, require steroid administration. The breathlessness can be due to involvement of the respiratory or the cardiac system in patients with rheumatological disease. So you require a good examination of the cardiovascular system and the respiratory system. And what's very important in examination of the respiratory system is please find out the presence of crackles, especially on the bases of the lungs, because that may indicate the possibility of interstitial lung disease. Extra-articular symptoms, abdominal pain, I told you. Abdominal pain in a patient with joint pain or a rheumatological disorder, what are all the causes? The first, abdominal pain, the cause can be related to the disease. In what way it's related to the disease? Vasculitis. Vasculitis is very, very important. The second one is it can be due to pancreatitis. Acute pancreatic pain can be associated with a disease called IgG4. Please read about this disease, IgG4 related disease. It's because what the mind does not know, the eyes do not see, is something which is relevant with respect to IgG4 disease. We are seeing a lot of IgG4 patients because we are aware, because of improved awareness of this particular problem. I shall talk to you about IgG4 disease in my next lecture. The second point is with respect to breathlessness is unrelated to the rheumatological problem is I told you it is anemia, and that anemia can be an iron deficiency anemia because nutritionally these people do not take adequate iron intake, so they have a nutritional anemia, and iron deficiency anemia can be the cause of breathlessness. The second important cause for anemia in patients with a rheumatological problem is normocytic normochromic anemia, which is an anemia of chronic disease in which there is defective utilization of iron in the bone marrow. So abdominal pain, we have finished. Burning micturition, we'll have to take into consideration post-urethritic reactive arthritis. But the other important fact is you have Reiter syndrome in which they have urethritis, conjunctivitis, and arthritis. The famous triad of Reiter, urethritis, conjunctivitis, and arthritis. So this is now comes to importance of an eye examination in patients with rheumatological problem. What is there with respect to the eye? Just take it this way, people can have conjunctivitis. Conjunctivitis occurs in patients with Reiter syndrome, urethritis, conjunctivitis, and arthritis. The conjunctivitis is bilateral and it is a sterile conjunctivitis. It is not infectious in nature. So that is with respect to the conjunctiva. Then we can go with respect to the sclera. It can be episcleritis or scleritis. Episcleritis and scleritis can occur in rheumatoid arthritis, systemic lupus erythematosus. It occurs also in vaginous granulomatosis or GPO or relapsing polychondritis. Never forget a painful red eye with defective vision. A painful red eye with defective vision is suggestive of uveitis, and uveitis is characteristic of ankylosing spondyloarthritis, ankylosing spondylitis. That's very important. Uveitis occurs in two rheumatological disorders. One will be spondyloarthritis, the second one is Behçet. Behçet is recurrent oral ulcers, recurrent genital ulcers associated with uveitis. Please mute, please. History of neuropsychiatric disturbances. A patient can come to you with fever, rash, oral ulcers, and neuropsychiatric disturbances. That is systemic lupus. And occasionally, psychiatric disturbances or organic brain syndrome can be a manifestation of systemic lupus even before the frank onset of fever and rash is there. So, very important, people with neuropsychiatric disturbances, you have to exclude the possibility of systemic lupus or even vasculitis. This, please never forget, history of stroke. Stroke in a young person, you will have to think of a condition called antiphospholipid antibody syndrome. What is antiphospholipid antibody syndrome? It is a condition which is associated with the hypercoagulable state. There are antiphospholipid antibodies which are very notorious to cause a hypercoagulable state. So people will present with arterial occlusion, or venous occlusion, or with recurrent pregnancy loss. And that is antiphospholipid antibody syndrome, which should be diagnosed, and these patients require lifetime anticoagulant therapy. So these people, how can they present? They can present with sudden loss of arterial vision. The second, they can present with a stroke. They can present with vascular arterial gangrene and venous deep vein thrombosis, pulmonary thromboembolism. They can present with. Just a second moment. So it can be causing pathology of occlusion in the arterial tree or the venous tree or recurrent pregnancy loss. History of genital ulcers in patients with rheumatological disorders, you'll have to think of Behçet. That's very, very important. History of Behçet syndrome, recurrent painful oral ulcers, and genital ulcers. All genital ulcers can be secondary to sexually transmitted diseases. Now, one important point when it comes to Behçet, the diagnosis is mainly clinical. History of oral ulcers and genital ulcers. But what helps to substantiate the diagnosis of Behçet is to do the HLA testing with HLA B5 and B51. HLA B5, HLA B51, and HLA B52 are characteristic, what do you call, genetic markers to make a diagnosis of Behçet. History of similar episodes in the illness in the past. Yeah, it just shows that there's an history of evolution of the disease into a specific pattern. History of valvular heart disease. I have a patient in front of me. He's got pyrexia of unknown origin. And I didn't ask him for a history of valvular heart disease. I'll be missing a diagnosis of infective endocarditis because infective endocarditis presents characteristically as pyrexia of unknown origin, peripheral polyarthritis, splinter hemorrhages, and features of emboli also. That's very important. So please ask for a history of valvular heart disease in any patient with joint pain who has got prolonged fever. History of hospital admission. Now, we can always say that rheumatological patients is an outpatient treatment, but rheumatological problems also have emergencies and they are admitted in the hospital. So that's very, very important. Your hospital admission in a patient will give a clue that this rheumatological problem has been of great morbidity and is also associated with mortality. Example, systemic lupus with characteristic renal failure can get admitted in the hospital. A patient with sarcoidosis can get involvement of the heart, cardiac sarcoidosis with an arrhythmia. So, history of hospital admission is very important in a rheumatological disease. Clinical examination. Clinical examination includes general examination. Nothing replaces clinical examination in clinical medicine. Nowadays, people straight, they go ask a few points with respect to the history and don't do a proper clinical examination. They do a clinical examination in 5 minutes and say, it's all right, there are no problems at all. You have to do a pakka dental examination. Examine for lymph nodes. That's very important because lymph nodes can occur in systemic lupus. Lymphadenopathy can occur in patients with lymphomas, which can have a rheumatological manifestation of arthritis. Joint examination. Whether the joint is warm, whether it is tender, the range of motion. You should record it. Spine. Involvement, you have to examine the cervical spine, the dorsal spine, the lumbosacral spine with respect to tenderness, with respect to movements. That's very important. If there is an acute pain localized to one spine, then you'll have to think of tuberculosis in this country. If the lumbosacral spine movements are decreased equally in all directions, you think of spondyloarthritis. The cervical spine has got decreased mobility, you will have to think of ankylosing spondylitis in these patients. A rheumatological examination is incomplete without examining the gait of the patient. The gait will tell you the diagnosis. Example, this 2 weeks ago, please mute, please. Example, Sorry for the break, like what we see in the television often. So we finished general examination, joint examination, examination of the spine, examine of the gait. There is something like 2 weeks ago, I had a patient who came with a painful limp on the right hip side, and he had undergone a MRA of the lumbosacral spine, which showed some intervertebral disc lesions, and he was diagnosed to have lumbosacral disc disease. On examination, there was restriction of the hip movement, and the gait was very characteristic of hip disease. We got an MRA of the pelvis of the femoral hips, which showed avascular necrosis of the femoral head. So that is the importance of seeing the gait of a person. We have an examination in rheumatology called GALS, that is gait, upper limbs, lower limbs, and the spine. So 4 components have to be done examination of in a rheumatological problem. Other systems examination doesn't mean rheumatologists don't require a stethoscope. So you should examine the cardiovascular system, the respiratory system, the central nervous system, the abdomen. All these things have to be examined. Recording of vitals. It is vital to examine the vitals. That's important. And all peripheral pulses. In my clinical practice, what I do is I always examine first the dorsalis pedis and the posterior tibial artery. Then I go to the radials, because I pick up patients with coarctation of the aorta and aorta arthritis and peripheral arterial vascular disease. Every patient with a rheumatological problem kindly auscultate over the neck for a bruit of aorta arthritis. Sometimes the pulses may not be unequal, but a bruit in the neck will pick up aorta arthritis, which has been my experience. See, experience is a province of wisdom, said the Buddha. I am now Buddha, but one thing, my long-term experience of 40 years has told me that you should examine the peripheral arterial pulsations of all patients with rheumatological disease. Why rheumatological? Every disease, every system, you have to see the peripheral pulses. So history has been taken, clinical examination is done, and then you come to the clinical diagnosis. So after that, you will have to come to a conclusion about joint pain, whether it is arthralgia or arthritis. So what is arthralgia? Arthralgia means pain in the joint. Arthritis means swelling in the joint, warmth in the joint, tenderness in the joint, restriction of joint movement. So that clearly you have to come to a conclusion. After clinical history and clinical examination, this patient has got only arthralgia. He doesn't have any arthritis. That conclusion you should come to. Then, in that situation, what are all the causes for arthralgia? Differential diagnosis of arthralgia. No arthritis. One, it can occur in the post-viral rheumatological problem like chikungunya-related arthritis or dengue arthritis. Hypothyroidism you should suspect in people with polyarthralgia. Many times I have made a diagnosis of hyperthyroidism. Hyperparathyroidism. Yeah, they have severe joint pain and abdominal pain. Vitamin D deficiency. That also causes joint pain. Osteomalacia. Very characteristic. They'll have a waddling gait, painful muscles, and very lot of joint pain they have. You do the vitamin D and the serum alkaline phosphatase and the PTH, they all will be elevated. It's characteristic of feature of osteomalacia. But vitamin D associated osteomalacia is a treatable disorder. You replace with vitamin D, the patient becomes fine. So please suspect osteomalacia or Paget's disease when patients present only with joint pain. Acromegaly also presents as joint pain. Iatrogenic joint pain, drug induced. Statins can cause it and quinolones can cause joint pain. There is an entity called palindromic rheumatism. Palindromic means it comes in episodes. Rheumatism means affecting the joint. Repeated episodes of pain in the joint, migrating from one joint to another, not associated with joint swelling. Very occasionally may have joint swelling, and that is a condition called palindromic rheumatism. Now, this is important. In the prodromal phase of hepatitis B and hepatitis C, people can have severe musculoskeletal pain and joint pain. Retroviral infection can present as joint pain. Polymyalgia rheumatica. Polymyalgia rheumatica is a disease of the elderly which presents with severe shoulder girdle pain and pelvic girdle pain. And they do not have any evidence of arthritis. The ESR will be about 100, and you do the test for myeloma, it will be negative. They respond dramatically to steroids. Just 15 to 20 milligrams of prednisolone you start, the patient will be up on the feet and keep walking around and experience a very painless state. Polymyalgia rheumatica is an elderly rheumatological disorder presenting with shoulder girdle pain and pelvic girdle pain with elevated ESR and all tests negative for malignancy, including a bone marrow. It is just don't think it is only seen in the West, it is also seen in India. So a high index of suspicion should be there to make a diagnosis of polymyalgia rheumatica. The last one which we think is a fibromyalgia. Fibromyalgia is a distinct rheumatological disorder. It is in the realm of the neurologist, the rheumatologist, the psychiatrist, the therapist, the psychologist. All of them have to work together in the treatment of fibromyalgia. You can read about it. But one important point, if you don't like somebody, you don't like a colleague, you hate him for something, you send him 2 cases of fibromyalgia, that fellow will start running away from you because it's a very difficult one to treat. But for point of empathy and pathetic of the patient, for what needs they require is tricyclic antidepressants can be given to them. Counseling is very useful to them. Cognitive behavior therapy is useful to them. Last but not the least, our famous yoga. Yoga is very useful for patients with fibromyalgia. So you examine the patient. With the history and clinical examination, you came to a diagnosis, it is only arthralgia, so you made a diagnosis. But if there is swelling in the joint, then you may call it as arthritis. So this arthritis can be arthritis only or with extra articular manifestations. It can be arthritis only with or with extra articular manifestations. Now we'll get into our clinical journey. Now the next 30 to 40 slides, it will be only clinical pictures, no theory at all. So arthritis associated with extra articular manifestation, constitutional like fever, think of rheumatic fever, and you can see classically the rheumatic nodule present on the spine, and the echocardiogram shows evidence of rheumatic valvular heart disease. So fever associated with joint pain, you'll have to think of rheumatic fever. This is very important. In a child less than 16 years of age, they can present with fever, with polyarthritis, with lymphadenopathy. Then you'll have to think of systemic onset juvenile idiopathic arthritis or systemic JRA. You see that the line over the abdomen, the child presents with lymphadenopathy, arthritis, and the other important point is hepatosplenomegaly is there. Along with that, rash on the leg called erythema marginatum, which will come and disappear. A characteristic feature of systemic onset JRA, the rash will occur at the height of the fever, and then it will disappear once the fever abates. It's very difficult to treat because they require sometimes long-term treatment. Systemic onset juvenile idiopathic arthritis should be thought of in children. This is important. Many a time, even the best physician has met his Waterloo in missing leukemia in a child or in an adult with fever and joint pain, not responsive to any non-steroidal anti-inflammatory drug therapy. Any person who presents with peripheral arthritis, temperature, and joint pain more in the night, very severe in the night, unresponsive even sometimes to narcotic antagonists, you will have to think of leukemia. And what is required is just a peripheral smear which will tell the diagnosis. It's a misfortune sometimes that patients do the complete blood count, but a peripheral smear is not seen. That's very important. The peripheral smear, in fact, has to be seen by the pathologist also to exclude a leukemic process. So this is the child who presented to me with fever, polyarthritis, and you can see how sick the child looks. Peripheral smear showed leukemia, and with treatment, the child settled remarkably well. The other condition which presents with fever, joint pain, and rash is very obvious. All of you know it. It's systemic lupus, which presents with alopecia. The alopecia can be a non-scarring alopecia or a scarring alopecia. This lady has got on the left side a scarring alopecia, and that rash is called discoid lupus. Erythematous, angry looking rash with complete loss of hair. It's a scarring alopecia. And she's got the classical butterfly rash on the face. That's very, very important. Blustery rash is seen in about 30 to 40% of patients with systemic lupus, and this rash becomes worse on exposure to sunlight. Photosensitivity is very common. That's characteristic of systemic lupus. Then fever with arthritis, just one single joint involvement. Please think of septic arthritis. Rheumatologists also have emergencies. Septic arthritis is a rheumatological emergency. You can think that rheumatologists are only chronic patients, they can go around and speak in CMEs like this. But they also have rheumatological emergencies. Example like atlantoaxial subluxation in a patient with rheumatoid arthritis, or cardiac pericardial effusion with cardiac tamponade in a patient with systemic lupus, or septic arthritis is the rheumatological emergency. Monoarticular joint involvement in a febrile patient, you will have to think of septic arthritis. The commonest conditions which predispose to septic arthritis are diabetes mellitus and patients on immunosuppressive drugs or people in immunosuppressive state like retroviral infection. So septic arthritis should always be in the back of your mind. The other important thing, please ask for a history of an intra-articular injection given in the past under septic conditions. Intra-articular injection should be given in the minor theater, not anywhere just in the OP. So that's very, very important with respect to septic arthritis and iatrogenic causes. And this is very important. I told you, no, fever, history of valvular heart disease, even peripheral arthritis can be there. You have to think of infective endocarditis, which presents characteristically with splinter hemorrhages as well as vegetations in the echocardiogram. That's very important. Think of infective endocarditis. Please jot down this point about infective endocarditis. Infective endocarditis can have positive elevated rheumatoid factor in the blood. It is a false rheumatoid factor elevation. Once you treat the infective endocarditis with antibiotics, the rheumatoid factor will become negative. So, in a febrile patient who has got elevated rheumatoid factor, think of infective endocarditis. This is a very important point. Many times this has helped me to make a diagnosis of infective endocarditis. Falsely temporary elevated rheumatoid factor in a febrile patient, think of infective endocarditis. That's important. The other condition which manifests fever and joint pain is aorta arthritis. That is why you'll have to examine, please mute, uh, is aorta arthritis. That's why I asked you to examine the peripheral pulses, including the carotids in every patient. And you see on the left side, there is a small line going across some artery is very prominent. This is collaterals in a patient with aorta arthritis. And then he had a lot of bruit over the neck. And the next one, it shows characteristic features of aorta arthritis in terms of occlusion of the subclavian artery and the left common innominate artery. So aorta arthritis is very important. It's called a young female arthritis, occurring more in the females than males, but it can also be seen in the 40 age group. The characteristic presentation will be prolonged pyrexia of unknown origin. PUO of unknown origin, you will have to think of aorta arthritis, and then you'll have to do an aortogram to make the diagnosis of aorta arthritis. Nowadays, we have very good biologics available for the treatment of aorta arthritis. Before, when I was doing my medicine, there were no biologics. Only treatment of aorta arthritis was anti-TB treatment. Now, the anti-TB treatment is kept in the therapeutic backbenches, and now the treatment of aorta arthritis is to give steroids, methotrexate, and also biologics like adalimumab or tocilizumab is given in the treatment of aorta arthritis. They do extremely well. So fever with fever with joint pain and abdominal pain, you'll have to think of polyarteritis nodosa. On the right side, you can see the typical rash of polyarteritis nodosa. They were all chronic ulcers and they have healed leaving scars. Heal leaving scars. And then you see the aortogram shows an aneurysm of the splenic artery. So important point is polyarteritis nodosa is a is one of the common rheumatological problems which you diagnose by great sense of awareness in you. That's very important. Abdominal pain, fever, vasculitic ulcers on the legs and upper extremities and lower extremities. Think of polyarteritis nodosa, and you would have to do an abdominal angiogram to pick up the multiple arterial aneurysms and stenosis. The other way in which you can do diagnosis of polyarteritis nodosa is to do a sural nerve biopsy, which will show evidence of vasculitic neuropathy. That's a very useful test. Sural nerve biopsy to be done in patients with suspected polyarteritis nodosa. This fever associated with ocular problems, you can see on the left eye that bluish sclera is there. This patient has got necrotizing scleritis. Necrotizing scleritis. Scleritis is inflammation of the sclera. Necrotizing is necrosis of the sclera. And once the necrosis of the sclera is seen, you can see the choroid behind, the bluish color. So that is necrotizing scleritis. And they also develop a saddle nose. The saddle nose, which is seen in patients with Hansen. Similarly, there is collapse of the nasal bridge in patients with granulomatosis and polyangiitis. So this is ANCA-related vasculitis, Wegener's disease, or now fashionably called as granulomatosis with polyangiitis. Paraneoplastic syndrome. Dermatomyositis occurring in the elderly age group. Please think of the possibility of a paraneoplastic syndrome because this patient you see has got in the mammogram has got a breast malignancy. Rash associated with joint pain. I told you it's systemic lupus. Characteristic butterfly rash, oral ulcers, cheilitis, and non-scarring alopecia. That's important. This is classical rash of dermatomyositis, a rash which is occurring around the eyes with periorbital edema. That's called the heliotrope rash, which is around the eye. And then you can see sort of hypopigmentation on the proximal aspect and the dorsum of the interphalangeal fingers called as Goitron's lesion or Goitron's rash. This is a characteristic rash of dermatomyositis. This is very simple for you to diagnose classical psoriasis, psoriasis in the abdomen. But on the other side, you see this is psoriatic arthritis. You see one toe, the first, second, third, fourth. The fourth toe is cylindrical. They call it as a sausage. I have not seen a sausage in my life. I'll have to go to UK to see sausage, but now I can't go. So it's a sausage-shaped cylindrical swelling of the fingers, which is absolutely pathognomonic of psoriatic arthritis. This is very important. Kindly look at the toes and the fingers. If one of them is cylindrically enlarged, then you make a diagnosis of psoriatic arthritis. That's important. Then this is psoriasis also involves the nails. And here you see the toe, they have nail pitting, ridging, onycholysis, and subungual hyperkeratosis. Every patient with arthritis, you'll have to examine the nails. You'll have to examine the nails, sorry. And then on the other side, you see psoriatic peripheral polyarthritis. Where do you look for psoriasis? You look look over in the scalp. Along just above the line of the forehead, you have to look behind the ears, and you look behind the breast, beneath the breast, around around the umbilicus. And then you'll have to look in the gluteal fold area. These are all areas in which psoriasis can be there and you will miss it. Ask for a family history of psoriasis, examine the patient for psoriasis, ask for a history of dandruff, and you make a diagnosis of psoriatic arthritis. This is a fantastic case. This is a characteristic patient with Hinoch-Schönlein purpura. Young child presenting with purpuric palpable rashes present on their legs and the palms. If they do a skin biopsy, it will show leukocytoblastic vasculitis. And if they do a skin immunofluorescence study, they will see IgA deposition. The pathognomonic diagnostic feature of Hinoch-Schönlein purpura is the histopathological evidence of IgA vasculitis. You may get it in an MCQ. Pathognomic evidence for Hinoch-Schönlein purpura is IgA deposition in the skin biopsy, mainly of the palpable purpuric rash. That's very important. Treatment of Hinoch-Schönlein purpura, I'll discuss later when I discuss about treatment in rheumatological disorders. Now, patients with joint pain with a history of cardiac problem, You see they have possibility of rheumatic fever, or it can be infective endocarditis. This patient actually presented with the gangrene and arterial occlusion, and you can see the impending gangrene in the fingers also. It turned out to be a very large agitation, and the whole pathology was thromboembolic phenomena causing these problems. This is important. It can be a cardiac manifestation in a rheumatological disease. Patient presenting with fever and breathlessness. You do an echo, it shows pericardial effusion. Think of SLE. Systemic lupus can manifest as pleural effusion, or they develop a pleural effusion during the course of the disease. In fact, I had a lady from Africa who presented to the emergency with breathlessness of unknown origin. When examined, then she had a cardiac tamponade. Her ANA is positive, her anti-dsDNA was positive, and then anti-Coombs test also was positive. She fulfilled all the criteria for SLE. She was taken up for surgery before, and then she became perfectly fine and discharged with steroids and mycophenolate mofetil. So pericardial effusion in this country, first you'll have to think of tuberculosis. That's important. As a diagnosis of exclusion, you'll have to do the gene expert TB mycobacterium in the pleural fluid. And you also have to investigate for systemic lupus. That's important. Pericardial effusion is common in patients with lupus. Pleural effusion. A patient can have joint pain associated with arthritis and pleural effusion. What are all the causes for pleural effusion in rheumatology? First but not the least, never forget tuberculosis in this country. They can have an associated tuberculosis because these patients are on steroids, immunosuppressive drugs, so they can develop tuberculous pleural effusion. Second important one is systemic lupus. SLE presents a classical pleural effusion, and see this lady has got a total alopecia, again with the mystery of malar rash, and the rash is going along across the nose. Now, arthritis associated with respiratory tract involvement. I told you basal crackles, systemic examination, interstitial lung disease, that they are seen in patients with rheumatoid arthritis. An active rheumatoid arthritis with multiple deformities like this, please auscultate the lung. Auscultate the lung in everybody. Especially this patient, you have to auscultate the lung for crackles. Characteristic crackles will be there, or rolls will be there, whatever term you like to use fashionably. So it is interstitial lung disease. Interstitial lung disease occurs in rheumatoid arthritis. Number two, it occurs in systemic sclerosis. See, this patient has got typically a pinched up nose, and then you see the lips are pursed, and this is characteristic scleroderma or progressive systemic sclerosis with CT evidence of interstitial lung disease. That's important. And what is this? The lady is putting her tongue outside and it is very dry. He's got dry eyes. This is Sjogren syndrome. Sjogren syndrome usually occurs beyond the age of 45 to 50. Characteristic will be dry eyes and dry mouth. They'll feel a gritty sensation in the eyes. Salivation will be inadequate, with the result they have dry mouth. I don't have Sjogren's. No, just imagine myself drinking water, but they take sips of water in between. And Sjogren syndrome is one problem which can be associated with two problems. One is interstitial lung disease. The second is renal tubular acidosis. That's important, RTA. Renal tubular acidosis can be a presenting manifestation of Sjogren syndrome. Interstitial lung disease can be a primary manifestation of Sjogren syndrome. The diagnosis of Sjogren syndrome, the hallmark diagnosis, is to do a submucosal salivary gland biopsy, which will show the characteristic lymphoplasmacytic infiltration. Serology-wise, you do the test anti-Rho and anti-La and ANA in patients with Sjogren syndrome. Then, pulmonary ILD, dermatomyositis. Dermatomyositis is a condition where they have a periorbital erythema, heliotrope erythema on the eyelids, and the Goitens patches, which I told you, which can occur on the fingers, dorsum. And number two, it can be associated either with malignancy, very important, paraneoplastic syndrome, or it can be causing interstitial lung disease, like how this patient has got an ILD. Then granulomatosis with polyangiitis, Wegener's disease. If you take an X-ray of the chest, it may show some nodules, which is confirmed by a CT in this patient, characteristic nodule of, of Mejiner's granulomatosis. So respiratory tract involvement can be there. They are present with cough, breathlessness, and hemoptysis. This is a very interesting slide. It's a $1,000,000 one. You see this sort of CT scan. This is alveolar hemorrhage. Any patient presenting with acute onset of breathlessness, hemoptysis, you find that the hemoglobin is very low. Think of alveolar hemorrhage. Alveolar hemorrhage, the diagnostic feature, you do a bronchoscopy, there will be blood in the respiratory tract. And the condition which you have to exclude is microscopic polyangiitis. Microscopic polyangiitis is affecting the smaller blood vessels. The other condition which presents with alveolar hemorrhage is Goodpasture syndrome, antiglomerular basement membrane disease. Alveolar hemorrhage can also be a manifestation in systemic lupus. It can also occur in people with microscopic polyangiitis, which is a vasculitis, small vessel vasculitis. So you'll have to think of that. Occasionally, antiphospholipid antibody syndrome can also present as alveolar hemorrhage. So acute onset of breathlessness in a person, one thing which you will think of is a tension pneumothorax. But very important respiratory tract wise, you can think of alveolar hemorrhage, get an X-ray done and confirm it with the bronchoscopy examination. Arthritis, joint pain associated with renal involvement, the first thing which we come to conclusion is systemic lupus. You see this boy, young boy, he's got pediatric juvenile systemic lupus. Such a scary rash he has got, and then renal biopsy showed evidence of lupus nephritis, and he had to be treated with intravenous cyclophosphamide and pulse steroids, and then he improved to a great extent. So 30 to 40% of patients with lupus have renal involvement, and SLE can manifest as a presenting system as glomerulonephritis, or the glomerulonephritis can occur during the course of the disease. That's very important to think of. Nephritis in a rheumatology patient, think of SLE. The second one I told you is granulomatosis polyangiitis. That causes a glomerulonephritis. That's important. Inoxaline purpura can also cause a glomerulonephritis. You saw the slide earlier. It shows glomerulonephritis. Then, the other important thing which you have to jot down is a patient with a rheumatological disease, you have been treating, and then you find urine loaded with protein, urine albumin 3 plus and 4 plus, and a urine PCR, protein creatinine ratio is more than 400 milligrams to 500 milligrams. Just think of NSAID-induced nephropathy. Non-steroidal anti-inflammatory drugs, when given for a prolonged period of time, can cause interstitial nephritis. Please think of drug-induced nephropathy. That's very important. So never forget of drug-induced iatrogenic nephropathy in patients with proteinuria in a rheumatological patient, especially rheumatoid arthritis, who is placed on long-term non-steroidal anti-inflammatory drugs. Similarly, if they are present with renal failure, we'll have to think of an NSAID nephropathy. The next one will be arthritis, joint pain associated with proximal muscle weakness. This patient has got polymyositis on the left side. We undergone a muscle biopsy of the left arm, and then that's a characteristic heliotrope rash which is present on the eyelids. This is characteristic of dermatomyositis. So muscular diseases, immunologically mediated muscular diseases can manifest as joint pain associated with muscular weakness. Hematological. You see patients with thrombocytopenia and you make a diagnosis of idiopathic thrombocytopenic purpura, also called as immunologically mediated thrombocytopenic purpura. Now, when some of these patients are followed up, they evolve into systemic lupus. So, systemic lupus can manifest as idiopathic thrombocytopenic purpura, or they can present just with thrombocytopenia. That's very important. And that's a characteristic lupus rash in this child who presented with ITP-like presentation, subsequently developed systemic lupus on follow-up. So we finished with respect to approach to joint pain, arthralgia and arthritis. Arthritis associated with extra-articular features. Then you said, no, no, there are no extra-articular features. So this patient has got only arthritis. So when it comes to only arthritis, you classify it whether it's monoarthritis or polyarthritis. What will be the causes for monoarthritis or polyarthritis? Polyarthritis is more than 5 joints are involved. If more than 5 joints are involved in a patient, you call it as polyarthritis. That is the definition of polyarthritis. This is classical rheumatoid. You can see symmetrical inflammatory polyarthritis associated with early morning joint stiffness involving the joints of the fingers and the toes, ultimately, when not treated, landing up with deformities. It's a shame for a rheumatologist to see a patient at this stage of the disease of treatment, because now rheumatoid arthritis is now something is an aggressive disorder like a double vessel coronary artery disease or a Hodgkin's lymphoma. So the point is we treat rheumatoid arthritis very aggressively. Maximal damage to the joints in rheumatoid occurs during the first 2 years of the disease onset. So earlier you had a pyramidal approach. We give NSAIDs, steroids, disease-modifying drugs. Now we tell start rheumatoid arthritis, start treating rheumatoid arthritis early, leave the pyramid to the Egyptians. So that is rheumatoid arthritis causing a peripheral polyarthritis. Then SLE can manifest as polyarthritis. Please remember, in a young lady who presents with polyarthritis, two important differential diagnoses you'll have to think of. One, it can be rheumatoid or it can be systemic lupus. Ask for extra articular features of a malar rash, photosensitivity, oral ulcers, excessive hair fall. That's very important. Differential diagnosis for rheumatoid in women is systemic lupus. This is polyarticular psoriatic arthritis. That's another cause for polyarthritis. This is very interesting. These people present with sort of nodules in the terminal interphalangeal joint region, and you see they develop deformities in the terminal interphalangeal joint. This is called Heberdean nodal osteoarthritis. Just jot down Heberdean nodal osteoarthritis. It presents with nodules in the terminal interphalangeal joint. It is a genetic disorder running in families. X-ray will show osteoarthritic changes in the distal interphalangeal joint. The greatness of this particular problem, it inflates your ego that you made a diagnosis of Heberdean nodal osteoarthritis, but you have to convey your condolences to the patient because there's no treatment for that. Unfortunately, in medicine, some of the diagnoses which we make, it boosts our ego, but it deflates it immediately because when you have no specific treatment for that, it's not curative. So Heberdean nodal osteoarthritis is one thing which can make a physician meet his Waterloo. That's important. Polyarthritis, infective endocarditis. Yeah. So monoarthritis. What are the commonest causes for monoarthritis? One is septic arthritis. I told you the causes can be diabetes mellitus, immunosuppression state, or on immunosuppressive drugs. It's a rheumatological emergency, and septic arthritis is very important. You have to ask for the history of intra-articular injection or intra-articular aspiration. Osteoarthritis, I don't think I need to speak about it. But one important point in osteoarthritis now is become talk of the day. They're trying to find out drugs which can actually cause cartilage regeneration. This is gout. One of the important causes for monoarthritis is gout. Classically, you see big toe involvement. Why it involves the big toe? Some people say that the temperature of the joint is least in the big toe. That's the way the crystals get organized. Some people say the big toe is highly prone to trauma, micro trauma. These are all theories, but not explained totally. But gout is very important. Please explain to the patient that gout is not curable. It's very important. Number two, look at long-term hypouricemic therapy. Number three, classical condition presentation is an acute onset of pain and swelling of the big toe of the first metatarsophalangeal joint, lasts for a few days and subsides by itself. Sometimes it's usually monoarticular, very rarely polyarticular. Untreated, they land up with persistent hyperuricemia and they can land up with multiple tophi. You see this page, the slide, the left side, the left toe, left side there's a tophi there. You can see that one on the ankle and one on the middle of the foot. That's all called gouty tophi, gouty tophaceous arthritis. And gout is equivalent to synonymous with increased uric acid. 30% of patients with acute gouty arthritis have normal serum uric acid. That's important. 30% of gouty patients have normal serum uric acid. So just because uric acid is not elevated in a patient with a first MTP involvement, you can't say this is not gout and walk away. It is gout. And what is the therapeutic trial for that? Give tablet of colchicine 0.5 milligram, one tablet twice a day or thrice a day. The gout will completely disappear in 3 to 4 days. So that's a therapeutic trial of colchicine will confirm the diagnosis of gout also. Last two slides. Tropical rheumatology. In my 40 years, what I have learned is most of the diseases which I've seen are diseases which are given in the textbook. But sometimes we see common diseases in a country which have rheumatological manifestations, but which have been given a stepmotherly treatment because of non-awareness of their existence. This lady presented to me with a rash on the cheek, multiple plaques on the face and the ears associated with inflammatory polyarthritis. My first diagnosis was systemic lupus. But somehow, I thought that it may not fit in with systemic lupus. I examined the peripheral nerve thickening, ulnar nerve is thickened. I examined the ear lobule, there were multiple plaques there. I did a biopsy, and the biopsy showed classical Hansen's disease in reaction, erythema nodosum leprosum. Erythema nodosum leprosum can manifest as systemic lupus, so please think of Hansen and examine the peripheral nerve. It doesn't require a lot of time to examine peripheral nerve thickening in patients with arthritis. So this is Hansen arthritis. We treated her and she became fine. So this I put it in the term as tropical rheumatology. So I come to the end of my presentation. I took 1 hour 15 minutes because I thought a pictorial presentation is very important from rheumatology point of view. So that now the carry home message on a weekend, Sunday, I really appreciate people coming and listening to me is diagnosis includes history, clinical examination, and investigations. A good history with a good clinical examination, you make the provisional diagnosis, which you confirm with investigations. Investigations doesn't mean you tick all the investigations present in the laboratory acquisition paper, but you do relevant investigations to clinch a diagnosis. That's very important. Then, after clinical examination, you come to a diagnosis whether it's arthralgia or arthritis. Arthralgia means pain in the joint. Arthritis means warmth in the joint, swelling in the joint, tenderness in the joint, with or without deformity. So you have to classify whether it's arthralgia or arthritis. Then if it is not, if it is arthritis, you will have to say whether the arthritis only or with extra-articular manifestations. Arthritis only can be monoarticular and polyarticular. With extra-articular manifestations, ask for fever, history of fever, rash, oral ulcers, then cardiac pathology, respiratory pathology, kidney pathology, eye pathology, so many other systems can get involved. So you'll have to ask whether there is arthritis with extra-articular manifestations. Then, if it's arthritis only, it can be either monoarthritis or polyarthritis. Mono, it's septic arthritis and gouty arthritis, which should never be forgotten. Polyarthritis, your classical rheumatoid. Exclusion of a systemic lupus as a differential diagnosis is very, very important. Last but not least, please do not miss the diagnosis of Hansen and reaction, which comes under the realm of tropical rheumatology. I come to the end of my lecture. I always love to quote Robert Frost and say, "The woods are lovely, dark and deep, and I have many promises to keep, and miles to go before I sleep, and miles to go before I sleep."